The first case is Arthur, who was diagnosed with schizophrenia in his 20s. Although most cases of schizophrenia become apparent in adolescence or early adulthood, it's important to remember that people with schizophrenia also grow old. Arthur's case concentrates on the optimal use of drug therapy and the advances that have been made since chlorpromazine was first introduced in 1952, half a century ago. The second case is Grace, aged 76. Her family is worried about some recent changes in her behavior. This case emphasizes the very difficult issues of diagnosis, including the need to differentiate between delirium, dementia, and depression in this age group. Let's meet Arthur, now aged 67. He had paranoid schizophrenia diagnosed when he was in his late 20s, and since then has been cared for by his older unmarried sister, who died unexpectedly 8 months ago. Arthur has been treated for years with fluphenazine decanoate intramuscularly at a dose of 25 milligrams every 2 weeks. The depot was administered at a local general practice. Arthur is a heavy smoker and has mild emphysema, which limits his exercise tolerance. Since his sister's death, Arthur's neighbors, a retired couple, have been taking him to the practice for his depot injections, and he receives meals on wheels, but he has trouble feeding himself because his movements are so slow. A few months ago, the neighbors noticed Arthur was disturbed at night. He wandered in the garden, lit fires in the backyard, and carried candles around the house. His GP added PRN thioridazine at 50 milligrams TDS. 4 weeks ago, after representations from his GP and review by an aged care assessment team, Arthur was admitted to an old-age hostel about 10 kilometers from his home. Treatment continued with fluphenazine decanoate and thioridazine. The hostel management has now asked a new GP to review Arthur and check that his medication is appropriate. They say he is settled at night and doesn't wander, but he doesn't mix with other residents, is socially isolated, and tends to be in a world of his own.
Arthur? Arthur, I'm Dr. Duncan. It's okay if I sit here? How are you today, Arthur? How's the hostel working out? They treating you all right?
Don't like the food.
What's wrong with the food? I heard it was pretty okay.
Don't like it. It's poison. They're trying to get me.
Who's trying to get you?
It's food. It's poison.
Okay, well, we might talk about that later. Arthur, I want you to stand up and walk across the room for me so we can see how you are on your feet today. Good. Now turn around and come back here. That's right. You can come and sit down again now, Arthur. Okay. Now, I want you to put your arms out straight in front of you with your palms facing downwards like this.
It's apparent that Arthur has significant extrapyramidal symptoms. The GP investigates these in more detail.
Okay. Now I'm just going to check your arms. Just relax. Good.
Arthur's arms have a high level of muscle tone. There is a sensation of cogwheel rigidity. The arms feel as though they are moving in a series of steps, rather than in a single smooth motion.
Okay, you can put your hand down again. Now I'm going to tap your forehead a couple of times, and I want you to try not to blink.
This persistent blinking is the primitive glabellar reflex, which usually extinguishes after 2 or 3 blinks. It is positive in Parkinson's disease and in Parkinsonism induced by drugs.
Good. Okay, now open your mouth. Right, stick your tongue out. Good. All right, Arthur. You can close your mouth now. Now, tell me more about how you're feeling. How are your spirits? Are you happy or sad?
I'm all right.
Are you scared or frightened about anything in particular?
Just the food. It's always the food. Put something in it. Trying to get rid of me.
Assessment of a patient's mental state should be a routine part of any consultation. Most of the information is gained by what you see, not by what you ask. The components of mental state are appearance and behavior, speech, affect and mood, thoughts, their form and content, perception, including the presence of any hallucinations, cognition, insight, judgment and rapport. In the next case, we'll look more closely at assessing cognition. But now it's time to discuss Arthur.